Good morning and welcome to the Sunday Echocardiography session. This is being conducted under the auspices of Indian College of Anesthesiologists, Forum of Cardiac Anesthesiologists, which is same as Bangalore chapter of IACA and the Indian Association of Cardiothoracic Surgeons. I invite you for this meeting, and we have two prominent faculties to take us through the subject of today, that is infective endocarditis. And before I actually hand over the stage to Dr. Sanjeevani and Dr. Parimala, who are our today's mentors, I would like to request you to keep all the mics muted and the video shut till the end of the talk, after which you can unmute if you want to ask any question. And you may also use the chat box function to pose your questions. Please keep all your mics muted, excepting the speaker and the moderator. All the mics must be kept shut till the end of the talk. With this introduction, I would like to invite Dr. Sanjeevani Imandar, so a very well experienced echocardiography skills, and Dr. Parimala Sinha, again very knowledgeable and scholarly cardiac anesthesiologist. With this, I would like to request Dr. Sanjeevani to take over. Thank you so much.
Thank you, Dr. Muralidhar, and I'm really grateful to you for continuing this medical activity. And it is always pleasure for me to moderate, introduce, be with my dear friend, Dr. Parimala. She is very calm, quiet, composed, and very good teacher. And we are lucky to have her today. And Parimala, please start your lecture on infective endocarditis.
Thank you, madam, for the kind introduction. Are you able to see my screen?
Yes, ma'am.
Okay. So today's topic is about infective endocarditis, which is a very huge topic. I'll go through mainly recent guidelines and some cases which we have recently done. So long back in 1885, William Osler said, few diseases present greater difficulties in the way of diagnosis than malignant endocarditis. So even today, there is no single test that will establish the diagnosis. So we use modified Duke criteria. The three criteria are positive blood culture, positive echo findings of vegetation, abscess, dehiscence of prosthetic valve, and third feature is new valve regurgitation. Either two major criteria or 5 minor criteria like IV drug abuse, fever more than 38 degrees centigrade, vascular phenomena, immunological phenomena, or microbiological evidence, that is a blood culture positive but not meeting the major criteria. So either 1 major and 3 minor or 2 major criteria are required to diagnose infective endocarditis. So we'll discuss about basic principles and echo features in infective endocarditis. Limitations are there. We will not be able to differentiate active versus healed vegetation or a non-bacterial infective endocarditis with echocardiography. And there are difficulties with prosthetic valve endocarditis. Then what is the clinical utility in suspected infective endocarditis? We'll discuss. There are 3 main echo features of infective endocarditis. One is vegetation on the leaflet or a device, then abscess formation and a paravalvular leak. So the case, 18-year-old boy was he presented with fever and acute lower limb ischemia pain 1 month after Ozaki procedure. Blood cultures grew 1 hours. Transthoracic echocardiography showed satisfactory valve function with no obvious vegetations. And there was concern about infective endocarditis. High suspicion was there, so T was performed. Again, no obvious neo-aortic valve vegetations were found. The question is, when should echocardiography be repeated in such patients? Should it be with TTE or TE, or any other advanced imaging method is required in this situation? So infective endocarditis is a dynamic process. There is infective valvulitis before a discrete vegetation is visible using echocardiography. So when there is high suspicion and both TE and TE are negative, ideally we have to repeat it within 5 days. And if urgently we need to diagnose, there are advanced imaging modalities like cardiac CT or a hybrid procedure like FDG PET CT. So only in conditions where the bacteremia is resolving because the infected line was removed, or if there are no high risk features, then repeat TE may not be required. Comparing ACC versus ESC guidelines, both are almost similar. In ACC guidelines, both TE and transesophageal echocardiography are first line of investigation, whereas in ESC guidelines, initially transthoracic is advised, and repeat TE or TT is required within 7 to 10 days according to ESC guidelines, within 3 to 5 days in AHA guidelines. So this is a algorithm. When there is possibility of a high suspicion of infective endocarditis, especially in a prosthetic valve, repeat echo is required, or the hybrid PET CT or SPECT CT or any other imaging modalities for embolic events like brain MRI may be advised. Again, modified Duke criteria are applied, and we can go ahead with the diagnosis of infective endocarditis. When echocardiography TE is also not showing vegetations, a CT and this PET CT will show the higher activity due to infective endocarditis with perivalvular abscess formation in the early stage. When CT is not available, then even MRI will show. In this patient, MRI showed perivalvular abscess in the aortic valve. So these are class 1 indications for TT and TE in European guidelines as first line of imaging modality in suspected infective endocarditis. For TEE, in symptomatic patient, if TT is non-diagnostic, so this is the TE is required to assess severity of valve lesion, or if blood culture is positive in valvular heart disease, then also TE is required. And to diagnose complications of infective endocarditis, prosthetic valve endocarditis as a first line of investigation, TE is required. It's also useful in pre and intra-op management of infective endocarditis. The sensitivity of TTE for native infective endocarditis is 75%, but it reduces to 40% with prosthetic valve. That is why TE is better, and TE is better for mitral valve involvement as it is a posterior structure. TE features of embolism risk are highly mobile vegetation of more than 15 mm, as the risk increases to 83%. 3D-T is more beneficial in diagnosing infective endocarditis, and if the size is more than 20 mm in mitral valve, there is high risk of embolism, and mortality is high if vegetations embolize. So this 3D picture shows a perforation in the AML as well as vegetation attached to the mitral annulus. So the general considerations in infective endocarditis are, there are various organisms, but commonly Staphylococcus and Streptococcus infection is prevalent. Then risk factors are poor dental hygiene, kidney disease and diabetes, IV drug abuse, valvular heart disease, prosthetic valves, even bioprosthetic valve, and previous history of infective endocarditis increase the risk of infective endocarditis. Our goals of echocardiography are to see the vegetation, what is the effect of vegetation on valve function, underlying valvular pathology, impact of valve dysfunction on LV size, and the pericardial effusion or paravalvular abscess and other complication detection. So there are some definitions. Vegetation is an oscillating or non-oscillating intracardiac mass on the valve or any other endocardial structure or on implanted intracardiac material. Abscess is thickened, non-homogeneous perivalvular area with echodense or echolucent appearance. Pseudoaneurysm is pulsatile perivalvular echo-free space with color Doppler flow detected. Perforation is interruption in the endocardial tissue. So this image shows a perforation and communication with color Doppler we can detect. Even pulse wave Doppler will help to establish the flow across the valve. In this transgastric basal short axis view, we are seeing the mitral valve with the vegetation being seen in the orifice. And if we see posteriorly in the inferior wall of myocardium, there is an echolucent area and it is communicating with the valve orifice. So this is a possibility of abscess near the posteromedial commissure. The other problems that we see is perforation, interruption of endocardial tissue continuity traversed by color Doppler flow that we saw earlier, a fistula formation, that is communication between two neighboring cavities through a perforation. A valve aneurysm is saccular bulging of the valvular tissue. You can see in the mitral valve, there is a saccular bulging. Usually it is perforated and communicates with the left atrium. Here the aortic valve, it's a bicuspid aortic valve with aneurysm formation of the non-coronary leaflet, which is seen in the aortic long axis view. There can be dehiscence of a prosthetic valve with paravalvular regurgitation and with or without rocking motion of the prosthesis. So vegetations are infection of the endothelial lining of the intracardiac structure. These contain bacteria as well as the thrombotic material. You can see here there is a bioprosthetic valve which has developed infective endocarditis, and you can see the vegetation appearing with 3D echo. These can appear on the valve or devices or in congenital lesions like PDA, VSDs. Recently we had one ASD PAPVC with pulmonary valve endocarditis. And 20 to 50% of the vegetations embolize and are fatal, especially in the left side of the heart. The differential diagnosis for vegetations are Lichtman-Sachs endocarditis in SLE, a TOR torn chordae or elongated chordae can confuse with vegetation, lambels, excrescence, and nodules of Arrhenius in the aortic valve or fibroelastoma, myxoma. A free suture end usually is confused. Then LB false tendon may cause confusion. Non-bacterial thrombotic endocarditis will not be able to differentiate from infective endocarditis. The other one is beam width artifact. If we see the beam width as it expands distally, it will not detect if the artifact is outside the beam width, but if the artifact appears within the beam width and it is getting refracted, and it will be seen as an artifact on the valvular surface or other structures. So the characteristics of vegetations are, if organism is streptococcus or fungi, they are larger and globular, whereas gram-negative and enterococci have long filamentous. This is a feature may be suggestive of a particular group of organism, and size increases with duration of infection. Echogenicity of the vegetation is similar to myocardial texture. Location is in the mitral valve, it is on the atrial side, and aortic valve, it is on the ventricular side. It may get calcified in if it is a long-standing vegetation. It may be fixed or oscillating independent of the valve motion. You can see it is moving independent of the valve motion and causing valve obstruction. So vegetation risk score has been suggested for complications of embolization. So from grade 1 to grade 4, which is a fixed lesion with free edge, grade 3 is pedunculated, grade 4 is prolapsing. The mitral valve infective endocarditis, especially on AML, has the highest risk for stroke, whereas aortic valve vegetations are more refractory to antibiotics, complications are more, mortality is higher. If vegetation size reduces with antibiotics, the prognosis is better, but embolism can occur even after treatment. There are various mechanisms for valvular regurgitation in infective endocarditis. First is perforation of the leaflet from the abscess, which we saw here. You can see the perforation and leaking valve. Then second is impairment of leaflet coaptation by prolapsing vegetation. So this will not allow proper coaptation, and there will be severe mitral regurgitation or leaflet prolapse or flail chordae. This also will lead to severe mitral regurgitation. This is 62-year-old patient with history of degenerative mitral valve disease, presented with fever, night sweats, chills, shortness of breath, and lethargy for 1 week. His blood culture grew group B streptococcus, and transthoracic images showed several severe mitral regurgitation with possible torn chordae. He was treated with antibiotics and referred for surgery. Intraoperatively, degenerative mitral disease with ruptured chordae tendineae and vegetations at the posterior leaflet were found. This is transthoracic echo showing severe mitral regurgitation and vegetation. The LA is enlarged. The EF is 70%. So he had a good LV function. And he underwent surgery. Now, indications for surgery are mainly complications of left-sided valve endocarditis, or like heart failure, uncontrolled infection, for prevention of embolism. These are Most of them are urgent surgeries. And if patient is in pulmonary edema, cardiogenic shock, it is an emergency surgery. So these are class 1 and 2A indications for various lesions. So briefly, class 1 indications are native valve and acute endocarditis, a patient with valvular heart disease and congestive heart failure, or acute severe MR or AR with elevated LVEDP, fungal or resistant organism causing endocarditis, and complications like heart block, abscess, or obstructive lesions require surgery. Class 2A is persistent vegetation or recurrent emboli despite antibiotic therapy. Class 2B is mobile vegetation more than 10 mm. For prosthetic valve, it is heart failure with endocarditis, valve dehiscence, regurgitation or obstruction or abscess. Class 2 is recurrent infection, and routine surgery is not indicated in the first infection. So we'll just see acute aortic regurgitation or mitral regurgitation with heart failure requiring indication. So pre-bypass TE will help to know extent of infective endocarditis, location and size of abscess, involvement of other chambers, and to know ventricular function. This patient had mitral valve endocarditis and there was severe MR, and if you can make out, it is a perforation of the anterior mitral leaflet. This is another case with causing mitral stenosis due to vegetation, and there was severe moderate MS 19/8 of mitral gradient. So these patients were subjected for surgery. After surgery, if repair is done, if there is moderate MR, then there is question of whether it is requiring redo surgery. So more than moderate, we need to address these, otherwise they'll come back for redo surgery. A mild leak, this is a bioprosthetic valve with paravalvular leak of 2 mm. So these patients may be observed. The prognosis for embolic risk is high with the vegetation of more than 15 mm, neck to thickness ratio of more than 0.69, maximum angle of displacement of vegetation more than 60 degree. And during antibiotic treatment, risk mainly depends on mobility and dimension. This is according to this paper. So predictors of poor outcome are patient characteristics are older age, prosthetic valve endocarditis, diabetes and comorbidities. Clinical complications like heart failure, renal failure, stroke, brain hemorrhage, septic shock are high risk. And staphylococcus, fungi and non-HACEK gram-negative bacilli have higher or poorer outcome. Echo features of periannular complication, abscess, severe left-sided valve regurgitation, low EF, pulmonary edema, large vegetation, prosthetic dysfunction, premature mitral valve closure, and other signs of elevated diastolic pressure are poorer outcome. So in this study, they have found that a maximum vegetation length of more than 15 mm in 2D and angle of displacement more than 65 degrees are high risk for emboli. So they have suggested this calculation of maximum length perpendicular and parallel to the leaflet and the mobility to risk calculate. Now, few points about prosthetic valve endocarditis is its incidence is 1% during first year and reduces to less than 0.5% subsequently. If there is suspicion of infective endocarditis, TE is required. It helps in detecting vegetation, abscess, paravalvular leak or dehiscence, holes in the bioprosthetic leaflets. High negative predictive value if repeat TE is negative for infective endocarditis. urgent surgery is essential as poor response to medical therapy is seen. So indications are intractable heart failure, valve dehiscence or dysfunction, heart block, annular abscess. These non-HSEK, that is Haemophilus aggregatibacter, Cardiobacterium, Eikenella and Kingella organisms. Highly antibiotic resistant organisms. We had recently a Brucella endocarditis after Ozaki. Patient underwent redo Ozaki as well as required antibiotic for 6 months almost. Persistent bacteremia despite antibiotics for 7 to 10 days is an indication in prosthetic valve endocarditis. This is the rocking motion and mitral regurgitation seen in the prosthesis. So these paravalvular leaks are usually pathological and they require surgery or any other intervention. But with active infection, this device closure is not advised. And in this particular patient device, you could see that it was very unstable and it immediately embolized and was seen in the left ventricle. Attached to caudate tendinae. Prosthetic endocarditis will be underestimated by 2D. You can see here hardly any regurgitation seen, but there is a huge vegetation. So there is a study comparing 3D versus 2D, and they have said that in prosthetic valve endocarditis, 3D is better for detecting vegetation, dehiscence, abscess, or regurgitation. So features of severe mitral regurgitation in prosthetic endocarditis are paravalvular leak. Dehiscence of the leak is a smaller area of defect, but it can have severe MR. Dehiscence is if more than 40% of circumference is having a defect. It also leads to severe MR. Forward flow is increased, but with a normal pressure half time. And jet vena contracta more than 7 mm and PISA more than 1 square centimeter suggests severe MR. Shoulder in continuous wave Doppler is seen due to C rise in the LA pressure. Aortic prosthetic regurgitation features are again paravalvular leak or dehiscence, premature mitral valve closure, and shortened mitral E wave deceleration time, increased transaortic flows. There will be difficulty to measure jet vena contracta. PISA is more than 1 square centimeter, pressure half time less than 200 milliseconds with flow reversal in descending aorta. These are features of severe aortic regurgitation. Now a few points about tricuspid valve vegetation. Usually transthoracic is enough, but in some patients, especially if there are pacer leads causing infective endocarditis, then TE may be required. These are going to require removal of the lead. And indication for surgery in right-sided infective endocarditis is microorganism difficult to eradicate, similar like fungus, or bacteremia for more than 7 days, despite adequate antimicrobial therapy, persistent regurgitation, and vegetation more than 20 mm, or with pulmonary emboli, with right-sided heart failure. All these require consideration for surgery. So in summary, echo helps to decide the potential surgical intervention like severe regurgitation, paravalvular abscess. Timing of surgery is decided by LV dysfunction, multiple valve involvements, pH development, recurrent embolization, and it helps in predicting short and long-term prognosis. Like sequential TE predicts whether antibiotic therapy is effective in reducing the size of vegetation. The risk factor for mortality are prosthetic valve involvement and systemic embolization, Staphylococcus aureus infection. Long-term outcome depends on residual valve damage, effect of valve regurgitation on LV function, pH, and risk for recurrent endocarditis. 3D has a better imaging facility, especially in prosthetic valve endocarditis, to detect complications of infective endocarditis. And 3D measurement is usually more than 3.2 millimeter compared to 2D measurement. Shape and attachment of vegetation is better visualized with 3D. And in 3D, if mitral vegetation is more than 20 mm, there is a high risk for embolic event. Thank you.
Thank you, Parimala. It was excellent and complete coverage of this topic by you. And I'm
Thank you.
sure the audience has got tremendous knowledge about this very serious entity that is infective endocarditis. So I welcome all the questions from the audience. You can speak, ask, open your...
Good morning, ma'am.
Yes,
This is Dr. Yashwendra. I have two queries.
yes.
One, we have seen the various indications for surgery in infective endocarditis. But if patient's blood culture is repeatedly coming positive, shall we wait or shall we just go in if, say, patient is in failure? That is one. And one more question is there, which is not really related to the topic. If a patient is suffering from malignancy, placing him on CPV, does it increase the chances of becoming, localized disease systemic, metastatic? These are my two questions. Thank you.
Yeah.
Okay, Parimala, please.
Yeah, persistent blood culture positive infective endocarditis with heart failure is an indication for surgery. So usually the cardiologist refer when patient is in failure requiring inotropes, and we can take up with high risk. Malignancy, we have done 1 or 2 cases with malignancy, though earlier days, if the survival is less than 1 year, then open heart surgery was not advised. We have done one patient with lung carcinoma for aortic valve replacement when he was severely symptomatic, and patient perioperatively did well. I don't know about the spread of malignancy after open surgery.
So my query is there any document or any paper which suggests that placing patient on CPP is going to increase the chance of metastasis if he is having submalignancy? So that is one. And secondly, the worry about when the patient is culture positive. Am I audible?
Yes, but
So
please
placing
speak
him on
little
CPP,
louder.
all right, ma'am. So placing him on culture positive, don't we, have higher chances of vasopressor shock and difficulty in coming of bypass?
Yes, the risk is high, but still it is to save the patient only we would take up when cardiologists fail to control infection with antibiotics.
All right. Thank you.
We have done few cases like that.
Can I just come in to answer his
Yes,
the first question about
sure.
Yeah. See, there are a couple of papers which have actually studied the incidence of distant metastasis in a situation of primary malignancy and patient requiring cardiac surgery. Though the correlation has not been completely established, but whatever number of cases they have studied, there is a marginal increase in distant metastasis in these patients, especially when you are operating patients, especially when you are doing cardiac surgery on patients who have pulmonary malignancy. The incidence is relatively higher compared to other malignancies. But yes, there is a slight increase, and one has to basically understand the risk of operating early, doing early cardiac surgery or early malignancies. If you have patients who are having LMCA or critical lesions requiring bypass, the risk of surgery in that situation, surgery for malignancy will be much higher. So one has to basically compare the risk of surgery operating with cardiac element first, cardiac surgery or the malignancy. But there is a marginal increase.
Sir, I'll request if you can just share those papers in the group. That is one thing. And secondly, I mean, practically from what you're saying, I understand that we are not justified in delaying this cardiac surgery, even if the patient has got malignancy, considering the risk is slightly higher, not really significantly higher, of metastasis.
Yes.
Hello?
Yes.
Yeah.
Yes. It's always a balanced situation, and you have to weigh the risk and benefit. Risk-benefit ratio is very important, and we have to explain to the relatives about this situation very well in advance, and one has to go ahead.
Yeah, in our patient, there was lung malignancy and patient had severe AS with symptoms. And those days we didn't have TAVI. So AVR was required in that patient.
All right. Thank you.
Any other question?
Did that patient develop any metastatic carcinoma? Did you follow up that patient?
I'll require to ask with my surgeon, sir.
Sure. The evidence shows that if you put patients on bypass when in the presence of cancer, that is malignancy, the risk of dissemination is logical, but it says that it's unlikely, as one of our participants noted that the changes are not significant. I mean, the association is not significant of the dissemination. That's what the literature is saying. And whenever possible, if there is cancer, I mean, malignancy associated with the heart lesion, and both need to be done, probably we should choose a technique where there is, interventional technique should be preferred as far as possible.
Thank you.
As you said, TAVI could have been a better option.
And also, whenever there is a possibility of operating both simultaneously. In fact, we recently operated a patient who had CA breast. So we took the patient in CVTSOT. The oncosurgeon did surgery for CA breast, and then we went ahead and did CABG for that patient.
Absolutely correct. Absolutely correct. I agree with that. If the facility of general hospital with all the departments are available, after having a multidisciplinary team meeting, we can do both the lesions together, both the surgeries together. And again, you want to do or the non-cardiac, and then the optimal results can be obtained. And we have found that there's no increase in morbidity or mortality. In fact, the patient undergoes one surgery, one episode surgery, you can tackle the lesions, and with good results can be provided with optimal
Thank you
care.
for all the calls.
Thank you.
Okay, let's.
There is a question.
Yeah, I will just go through the chat box.
Yes,
Parimala.
please.
This one question is from Mujahid. If biomarkers are high, we have to wait or operate. You have answered that.
We usually wait till the bacterial cultures are negative, patient is cured of infection. Only surgery is required when there is intractable heart failure or abscess and other complications which medically cannot be treated.
Yes. That's a question actually, very important scenario in perioperative period. Another question from one anonymous is differential diagnosis of vegetation on the valve on echo other than clinical history. Ruptured papillary muscle also looks like vegetation or mass. Any differentiating points, madam, to differentiate between vegetations and these ruptured papillary muscle? That is what I think he means. I think you have told about echo mimics of vegetation.
There are differential diagnosis and clinical history and other features we have to look at before we say it is infective endocarditis or innocuous condition or previous history of patient, whether patient earlier had some valve lesion and he has now come with either ruptured chordae with severe MR or infective endocarditis. I think we can differentiate with the modified Duke's criteria applications.
I would like to add over here, all the attendees, that infective endocarditis is always to be correlated clinically. That is first line. They always say that you correlate clinically. Clinical scenario is very important. Fever and history of valve surgery and all those things, or some intracardiac devices. So then only you can come to this diagnosis of infective endocarditis. There is another question that from Neda Kumaran. Can we say that if there is no regurgitation, less likely infective endocarditis?
No, actually one case I just showed, patient had mitral stenosis features, but there was a large vegetation. So presentations may be varied. It could be regurgitation or stenosis. Even if the vegetation is not causing any valvular functional abnormalities, we may not see a severe regurgitation or stenosis, but still patient has infective endocarditis.
I think why he has asked this question is regurg is more common. So that is why stenosis is less common. That is why. Okay, then this Gopal is asking the Sunday class presentations that were done from January 23 were not uploaded.
I have to answer that.
Okay.
The thing is, all the presentations are screened, and if there is an error or some miscommunication, such presentations may not be uploaded, but good ones with quality presentation, they're all uploaded. I think I'll put up the list which have been uploaded in the next message by tomorrow or day after. Yeah.
Okay. Thank you.
One more submission, madam. Like, though it is much beyond the scope of this group, is a role of cytosorb in surgeries on patients with infective endocarditis. I think when you are in a desperate situation where you have to operate in a positive culture or high biomarker status, I think cytosorb does have a big role to play.
Cytosorb, very nice question. I would congratulate you for bringing up this issue. Cytosorb filters, they have been tried in septic patients with equivocal results. They have not become the standard of care. Having said that, in patients who have long bypass, for example, long aortic surgery or pulmonary endarterectomy, these filtration devices may be useful to remove the vasoactive substances which are released during cardiopulmonary bypass. And I think that there are some European centers, they use cytosorb or these filtration devices during bypass in long cases or complicated cases. Regarding the specific question in the patient with vegetation, we have no literature support for the use, but it's a good question. We have to think about it and see whether it helps the outcome. Thank you.
Thank you.
Parimala and Sanjeevani can give their inputs.
Parimala.
I'm not familiar. I'll have to find out.
Okay, there is another question from Rohini. Is there any role for device closure in an acutely decompensated paravalvular regurgitation with positive blood culture?
It is not advisable. Only healed endocarditis with paravalvular leaks, they may be attempted with device closure. With positive blood culture, I think it is not advisable to go with device. Again, that will get infected and or we see complications.
It will not give the result.
What if you know the organism and the sensitivity and the patient is in failure? Under the cover of antibiotics, can you do the device? I'm not sure. I'm just wondering because of the question which has been asked.
I went through literature. That's what I read, sir. It is not advised, but maybe desperately we may try.
The question, can I say something?
Yes.
The question will come only this PV leak is causing heart failure or any certain. Otherwise, one can wait.
Patient is having hemolysis and anemia of hemoglobin 6 or 5.
Or
so we
acute
cannot
heart
wait for a
failure.
long time.
No, logically, it appears that the device might reduce the paravalvular leak, but the biggest problem would be embolization of infective endocarditis, because then you would be putting too many wires through the infected valve. So that may not be a great idea.
Yes. So, anyone having any question? This is important. Parimala, I would like to ask about this. How come having some infective endocarditis? Is there any difference as compared to the classical features of infective endocarditis?
Whether that vegetation is on the valve leaflet or on the
Correct.
surface.
Yes, that is the striking difference regarding HOCM, that it is on AML rather than the upstream because of the SAM and causing the friction on the interventricular septum, or it may be in LVOT also. So that is the striking difference. And sudden AV block appearing in the scene, patient otherwise normal and sudden AV block, if they occur, one can suspect having, high suspicion is the key in this topic. You have to have all the time suspect. So we have to play the role of Sherlock Holmes over here. Suspect and suspect.
Yes.
So it was a nice...
There is a comment from a senior surgeon who says that no surgery should be done unless infection is fully controlled. The senior surgeon is saying, so I think it's a...
Any surgeon would say that, I think. Any surgeon. Thank you for that input. There is another question popped up from Swarupa. How do you differentiate healed vegetation versus acute vegetation on echo? I think she has mentioned it. Parimala.
Vegetation alone will not be differentiated whether it is acute or healed one. But other echo features like sudden or worsening regurgitation in a patient known with endocarditis, or other features, we have to go for clinical features again to know if it is active infection or chronic healed vegetation.
Can I say something over here?
Yes.
See, this healed vegetations, the size becomes less. It is involuted. Another thing is it becomes more echogenic, that is calcified. And patient clinically improves. As I said, clinical involvement is very important. So then one can say that it is healing. Because otherwise the vegetations are, not echogenic. They are amorphous looking or frond looking. Frond is the word they have described, like serrated leaves. They are irregular. When they are very concised, healed and calcified, one can say that they are healing. So one can wait.
Sanjeevani, I do not know, but you can correct me. Can I say that acute vegetations are more mobile than the healed vegetations?
Yes, absolutely.
Fixed. Yeah.
Yeah, they have. Parimala has actually shown in one image that how much movement and how they are, they are very, one can say malignant emboli, ready to embolize, malignant vegetations. So, and one should, here I would like to say that the anatomy around the aortic valve is very important. Like, it can go, abscess can go to pericardium also, causing hemorrhagic pericardium, or to AV node causing AV block, or causing fistula, as Parimala has said. So one has to correlate with anatomy also.
Yes. Any other question or comment? If there are none, I would like to thank both Sanjeevani and Parimala for that excellent session, which generated some discussion. And I'm grateful to both of you for joining us and doing this session for us. And we would like to see you once again sometime. Please join us. And I would like to thank all the participants for being present and encouraging the show. Thank you so much. And we'll meet again on Sunday.
Thank you so much.
Thank you very much.
Thank you so much. Thank you so much.